All right. So, chapter 37 is all about brain injuries. Okay. We're going to talk about what a traumatic brain injury is, what an acquired brain injury is, closed and open head injuries, and all these different types. Okay. Because they are going to affect people a little bit differently. There's a couple slides in here about people. The only person I honest to God know that's in here is Tracy Morgan. I know him. I don't know anybody else. Does anybody else know these people? No, I didn't either. So Tracy Morgan is the one that I knew, American comedian. He has a traumatic brain injury from a car accident. And then there's some scenes from these movies. I honestly, the only one I've seen is 50 First Dates. So, all right. Hang on a second. This red box is killing me. Much better. Okay. So, but look up some of those movies because those actually have fairly decent portrayals of traumatic brain injuries. Okay. So let's talk about these differences. So an acquired brain injury is there's a couple different types. So a stroke is an acquired brain injury. So you might see a stroke labeled as an ABI. Okay. Drowning is an acquired brain injury, and not just clearly not to the point of death. I mean, that would be a reason for death, but you can get a brain injury from lack of oxygen. Okay. Because we've learned that a stroke is very simply not getting enough oxygen to the brain, either by way of a clot or from a bleed or from not breathing good quality air. That a stroke can happen. So drowning is the same exact thing, that you can get a brain injury from that. Drug overdoses can cause an acquired brain injury. And then anoxic or non-traumatic brain injury are also underneath that. And anoxia is the breathing. It's like hypoxia. Okay. Now, a TBI, this is injury to the brain from an external source. Okay. So everything here was more internal and it happened. So they took the drug and it happened internally. Or overdose on the drug, it happened internally. Drowning, the no oxygen in the brain, a stroke, these things happen internally to the brain. Okay. When a traumatic brain injury happens, it's something outside force. So getting hit in the head with a baseball bat. I don't know why that came directly in my head. I guess too much true crime documentaries, but car accidents, football injuries, that all happens with TBIs. Okay. External sources. So you have three different subtypes of TBIs, and then we're going to go through a whole bunch of different scales for TBIs today. The first one is a mild TBI is considered a concussion. Okay. So when somebody has a concussion, a lot of times we brush that off. That is a traumatic brain injury. Your brain has had some type of an injury to it in order for you to have a concussion. So when you see football players, a lot of them will go through and have like concussion protocols. They pull them out. That's because their brain was rattled with whatever hit that they had. And it may have caused a bruise or something like that to the brain, but nonetheless, there has been an injury to the brain. Moderate TBIs, what makes them in this category is if they lost consciousness for 30 minutes, at least 30 minutes, up to a full day, 24 hours. Okay. And then severe is very simply anything that lasted longer than 24 hours. At this point, it would be what's called vegetative. Persistent vegetative would be like coma. Okay. Pretty straightforward stuff. So let's talk about who's going to be on this team. It really just depends on how bad that the injury was. Was it to the point where they just had a concussion and, they were just rattled for a few minutes, vision got kind of blurry, needed a few days of rest, was out of sports or whatever like that for a week or so, or 2 weeks, depending on how bad the concussion was. So that's going to make a massive difference compared to somebody who has a severe brain injury and is completely in a vegetative state, right? So you're going to have anything from OT, PT, nursing, doctors, all over the place. Neurologists are going to be a huge part in this, especially when you get to moderate and severe brain injuries. And there's going to be a lot of different settings. They might just be seen in a primary care setting. They might have to go see their doctor afterward if they've had a mild concussion, anything like that. Or they could be in intensive care and be hooked up to a whole bunch of different machines. It literally just depends on how bad the injury was. Okay. All right. So we're going to start going through some of these scales. I want you to go to page 988, please, in your book. We're going to stay on this page here for a few minutes as we go through these different scales. These are two really common ones when you're talking about traumatic brain injuries. Now, if we're saying it's a coma scale, what are we talking about as far as the TBI? Where are we probably at? Right, we're looking at severe, right? So at this point, there's three different categories that they're looking at with this Glasgow coma scale. They're going to look at how much eye movement they have, what are their verbal responses, and what are their motor responses. Okay, I have a really good video I'm going to show you of somebody going through this here in just a few minutes. Your overall score can either be the lowest end would be 3, the highest would be a 15. Okay, so what is the lowest? This is very important. Lowest you can score, the highest. So can you score a 1 on the Glasgow coma scale? No. Can you score a 0? No, the lowest is 3. They're going to use this as an early recovery. The reason that this scale exists is it's trying to give a prognosis of how the client may recover. So if they have proper eye movement or proper movements in certain instances, then they may have a better prognosis for an outcome or a better outcome. Okay. I'll show you guys this video to show you what this looks like practically now.
To show you a practical way to some parts of the neurological assessment, the Glasgow Coma Scale. If you want to learn about all things neurosurgery, don't forget to subscribe to the Brain Book channel. The Glasgow Coma Scale was developed in 1974 by Graham Teasdale and Brian Jeanette. Every neurosurgeon will use it to assess a patient's conscious level, whether it's after an acute brain injury or if they're monitoring a patient in the intensive care unit. We've got the awesome CLO here with us today who's going to be our patient, and I'll show you how to do this quickly and easily. When you approach the patient at the bedside, you can get a lot of information about what to expect. If you're in the intensive care unit and the patient is in
very important, guys, pay attention.
They may have drugs on board that are going to affect the GCS scale. If you're seeing a patient on a Friday night who's been attacked outside of a bar, they might have a lot of alcohol on board. This is seriously going to affect your examination, so it's really good to know beforehand. The GCS rates a patient's conscious level according to 3 components: what their eyes are seeing, what they're saying, which is the verbal, and what they can do with their muscles, the motor bit. Each of those components is split into separate criteria. There are 4 for eyes, 5 for verbal, and 6 for the motor score. A normal response is the highest or best number, and the lowest is no response. The best score that you can achieve is 15, and the lowest is 3, not 0, never 0. Walk to the bedside and introduce yourself. Shout if you need to. Sometimes people might have hearing aids that have run out of batteries, or they've had skull fractures causing damage to their ears. Sometimes your patient will already be sitting up with their eyes open, having a cup of tea. If they open their eyes, then that is to sound. You can grab a pen or some kind of blunt instrument and apply pressure to the nail bed, starting slowly and increasing the intensity until they open their eyes or until you've put on enough pressure. You need to do this for at least 10 seconds.
So what I want you guys to do is be looking at your scale as you go through. And I want you, before he says it, look at your scale and see where that patient is at with that type of a response. So just as a practice run, he's applying pressure to the nail bed. So what is he trying to inflict? Pain. He's trying to inflict pain, right? Because that's a big part of the glaucoma. So if her eyes open to pain, where would she be rated on the glaucoma scale for the eye movement? 2, right? 2, because eyes open to pain. Okay. Are we good? Make sense? Okay.
Remember, you're not trying to hurt them, but you shouldn't be a soft touch. If they open their eyes to pressure, then you say to pressure. So far, not so bad, right? If they don't open their eyes, it's numb. Just remember that if both of their eyes are swollen shut from trauma, or a particularly horrendous wasp attack, for example, then you need to say that the eyes are not testable, or NT. Next, we're going to assess the verbal response. You don't need to go into a full AMTS, but just start talking to them, ask them if they know what their name is, where they are, and what month it is. If they get all of that right, then they're orientated. If they're not orientated and they're speaking in phrases or relatively complete sentences, then you can mark them down as confused. If they're talking gibberish with single words, most often swearing at you, that's words. If they're moaning or groaning and you can't make out what they're saying, then that's sounds. Things are starting to get a bit concerning by this point. If they've got a tube down their throat helping them breathe, it's kind of not testable, so put down NT. When you're testing the motor score, you need to ask your patient to perform a 2-step action, either grasping and releasing your fingers or opening a mouth and sticking out their tongue. If they can do that, they are obeying commands. You cannot use the peripheral stimulus alone to test the motor response. So you need to do something called a central stimulus. The first thing that we're going to show you is the trapezius pinch. Here, squeeze for up to 10 seconds and assess what their best response is. If the trapezius is not giving you any response, then you need to go to the supraorbital notch and use your thumb. Again, do this for 10 seconds and get the best response. If they move their arm or hand up above the clavicle towards the stimulus, that's localizing to pain. If the arm bends and moves rapidly away from the body and the stimulus, that's normal flexion. Abnormal flexion is when the elbow bends slowly and the arm comes across the body. Extension is when the elbows start to extend, and that's again a really bad sign. And if they're paralyzed, always put it down as NT. And remember to always make sure that you get the best response. Hopefully you enjoyed that video and you find it.
All right. I really like that video because I think that he describes this stuff really, really well. So whenever, hang on just a second, Sydney. So whenever you're doing this as an OTA, where do you think that you play the role as the OT practitioner? What do you think you have a role in with this glaucoma skill? That's exactly right. So you're not as the practitioner going in and doing the glaucoma skill. You may in an acute setting, but 99.99999% of the time, you're going to know they're a Glasgow level this, okay? Or they're a Glasgow score this. So when you see that, you'll be able to understand where they're at, which is this next slide. What I want to tell you is what are we looking at? So if they have a 13 to a 15, they have a mild brain injury, okay? So that's probably a what? A concussion, right? So if they score high on this glaucoma scale, it's a mild concussion or a mild brain injury. It doesn't have to be a concussion. If they do a 9 to 12, that's a moderate brain injury. And then if they go 8 or anything lower than 8, all the way to what? 3, that would be considered severe and not having a great outlook on recovery. Okay. Now, again, we never speak in absolutes, but severe is not going to have as great of a recovery as a mild brain injury, statistically speaking. Okay. What was your question?
So if something's non-testable, like you was talking about, how
Yep.
does the score not no lower than 3? Because if you're saying it's not testable, that takes away.
You would then take that portion out. So then your score would be a little bit different and you need to do a little, this is one of those random times where OT has to do a little bit of math. So if the eyes, for example, are swollen and you can't really test that, then you would put NT and then take 4 away from that 15 total, correct? So then you got to do a little percentage and then all that other stuff, but that's what you would do. Take it out of it altogether, put NT and test the other portions that you can test. Okay? Yep. Sorry. It's basic math though. It's not like an algebra equation. It's just a little bit of addition and subtraction. Yes. You would just take away the score that is associated with that section if it's not testable. Okay? And they would know why it's not testable. I mean, there would be a reason why it wouldn't be testable. If they're paralyzed, clearly that's not going to be part of the scale. Like that has nothing to do with the coma. They are paralyzed, right? Any other questions? This is just one of the scales that you're going to see, and it's more of a preliminary scale. Okay.
So if someone is paralyzed and like obviously they're a new patient at a hospital or they've been rushed to the emergency room or something, how do they know if they're paralyzed or if it's from whatever had
They'll
happened?
do nerve testing and stuff like that. Any other questions? All right, so now we're going to go back to this other scale. So this one's fun to say, but this is the Ranchos Los Amigos scales. Okay, Ranchos Los Amigos scales. What you're going to hear this is called is the Rancho scale is most commonly what you're going to hear it called. But there are 10, technically 11 levels. I'm going to talk about there's an added 11, but it just means that it's a little bit better. But anyway, we're going to go through this scale. So this is the reason that these scales exist is to help you understand what you're walking into with a patient. So basically what I want you to get out of this, you see on a patient's evaluation or on their chart that they're a Ranchos level 7, okay? You need to be able to picture in your mind what that patient looks like and be able to plan appropriate treatment interventions. Because your treatment interventions for like a Ranchos 1 or 2 are going to be very, very different from a 9 or a 10. Okay. Now, these levels can vary a little bit during the day. For example, like my dad with his stroke, his Ranchos level changes if he goes to work. If he has gone to work and he's added up money in his head all day and done that and made his brain work, he's a higher Ranchos level than if he just sat on the couch all day, had a relaxing day and watched TV. He's a lower Ranchos level than what he would be if he went to work and actually worked his brain some. Okay. So not all clients are going to go through all of these levels either. So they might not start at the very, very lowest end and then go toward the higher end. They might start at the higher end and only have a couple steps left to take. Okay.
So that vary, but with the Glasgow, it's not gonna vary.
Oh no, it definitely will vary as they come out of the coma. They both vary. A Glasgow coma scale though is more of a quick assessment type of thing. Where a Ranchos, you're in that level typically for a little bit longer. If that makes any sense. Not necessarily, no. No, this is specific for coma. You can kind of think of it the same way though. Yeah. Because you heal. Your body can heal from traumatic brain injuries.
So in our documentation with stuff like would we know what?
If you saw an increase. Okay. Good questions. All right, so here are the 10 levels, and we're going to go through each one of these. I promise you'll have plenty of practice with doing this before we're done with this chapter. So don't stress out about it, but here is I want you to follow along in your book. This is the exact table that's in your book, except for there is a level 11. So what is the worst level for a Ranchos? Right, a level 1. The best technically is 10. There is an 11th one that's added, but everything that I've ever found is always still at 10. 11's really just overkill in my opinion, but it's still there. All right, so we're going to come back to those ranchos levels and go in depth in each level, but we're going to continue talking about different types of brain injuries real quick. First, you have an open versus a closed head injury. These are very simple to remember because they're exactly what they sound like. If something is an open head injury, what happened? Their head was opened, right? They probably had a skull fracture, something along those lines. So it was an open head injury. Not rocket science to remember that, right? Closed head injury is what? Right. The damage was internal, so the skull was not opened. It's the exact opposite of it. Okay. Now, your two little subsections of TBIs that you're going to hear about is a diffuse axonal injury, or a DAI is what you're going to hear them called. Okay. Now, a lot of times the problem with brain injuries is they're not to just one area of the brain. A lot of times brain injuries tend to scatter and be in multiple sections of the brain. So that's what a diffuse axonal injury is when they do have this trauma, either open or closed, it doesn't matter. And they have injury to multiple areas of the brain, or widespread injury to the brain. Okay. This is one of the biggest reasons why patients will die from traumatic brain injuries, is because the injury has just gone all over. So if you have an injury, let's think about when you sprained your ankle, what happened? Thank you, but like physical, what did your ankle look like? It swells, right? Your brain does the same thing. So when your brain has an injury, it swells and it can cause even more injury. Okay. That would be a diffuse axonal injury, is that you've got injury to multiple areas or widespread injury to the brain. Again, this is one of the biggest reasons why patients with TBIs die. Okay. Let's put this in a practical sense, like a car wreck. Somebody, their head hits the windshield or whatever may be. That injury is not going to be just for that one spot that hit. It's going to be a diffuse injury. It's going to diffuse over the multiple areas of the brain. Okay. So when you see diffuse, I want you to think diffusion, right? Like it diffused onto the brain. Got me? The next one is the chronic traumatic encephalopathy, or a CTE. Does anybody know, or anybody ever heard of a CTE? No? This is one of the biggest reasons that football players have so many brain injuries. Okay. CTEs are small injuries to the brain, but repeated time and time and time and time again. So why is that common with football players? Because they get hit and they get hit and they get hit and they get hit. That's their job, right? So their literal brain is bouncing off of their skull constantly. Boom, boom, boom. And over a little bit of time, you're not going to probably notice anything, right? But our bodies are not designed to take blunt force like that all the time. So this is CTE is extremely common in NFL players. This is why you'll see a higher incidence of dementia and things like that in football players. You'll see lots and lots of football players get this encephalopathy, or the swelling, and it makes them not be able to function because it's constant repeated injury over time to their head. I mean, it's over and over and over. It's like, I know this sounds gross, but it's like picking a scab over and over and over. The first time, okay, it was just whatever, it'll heal, right? After time, it'll create a scar. If you kept picking after time, it's gonna make a bigger scar, and then a bigger scar, and a bigger scar, and it's never gonna go away. That's what CTE is. It's constant, repeated injury, time and time and time and time again to the brain. Yeah. We're gonna talk, well, not necessarily of CTE, but CTEs will be placed on a Rancho scale, and we are gonna go over those. Mhm. It could be some CTE going on. Basically what it does over time, what does your body do? Let's go back to the scab example. When it's building that scar, what is that scar? Anybody know on the cellular level? Basically what that is, it's a buildup of something. It starts with a P. Tissue is right at it, but it starts with a P. Proteins. Proteins. That's your body's building mechanism is proteins. So time and time again, when these little injuries happen to their brain, it's sending proteins to help build it up. And if it keeps happening, it keeps sending proteins and sends proteins and sends proteins. And basically what you're doing is you're starting to block off different pathways and things in your brain, and it makes it much harder for your brain to function. That's where you get the emotion regulation issues, you get the dementia, you get all these other different side effects of it. It's because your brain is trying to heal itself, but it's ultimately not healing itself. Oh yeah, we're going to talk about that in just a second. Yep. So yeah, that's a huge topic of sports. This is why there's foundations that want to get rid of football together as a sport 100% because it's so bad for the players. Now listen, you guys know that I freaking love football. It's my favorite thing in the whole world. I love it. Love all levels of football. It's one of my favorite things ever, but there is no denying how bad it is for the players' health. It's just not. I mean, sports in general, football doesn't have to be the only one. You know, wrestling can cause CTE. There's other sports. Football is just the biggest one because that's the name of the game is hit. And it doesn't have to be. A lot of people think that, oh, it's the wide receivers or the quarterbacks that are getting these injuries. A lot of times it's not. A lot of times it's just the linemen. And if you're familiar with the sport of football, there's the people that are on the line and they're just all they do is raise up and hit each other, raise up, hit each other. When they're doing that, they're causing these little injuries to their brain and these proteins to fill these spots. That's what makes this so dangerous. Yeah. Yeah, he had CTE. Yep.
MRIs or something.
Oh, no.
Like, you know how they'd have to do physical to football players.
It's like within
You would
like
think,
college level or
Yeah.
like something like that, they have to be able to pass certain tests.
Yeah.
To be able to be eligible.
Well, you have to ask yourself the question too of, are the players going to be willing to do that if the end result is you can't play football anymore? You know?
Like,
Hmm.
lied about.
Yeah, and a lot of players, yeah, a lot of players will lie about concussion symptoms for that reason. Absolutely. You know, think about it. You're a college athlete and you go all the way to the national championship game, the game before you have a concussion. You don't want to tell your coach because you're going to miss out on one of the biggest opportunities of your life. So I get it. I see but at the same time, is it worth dementia or a traumatic brain injury? No, it's not. So, but the punch drunk syndrome, this is another really common one is boxing. Because what are you doing in boxing? You're getting punched in the head. Okay. So that's, you know, of course it's going to cause brain injury. And the problem is people will throw out there, oh, that they've come a long way with helmets or, oh, they're wearing head protective gear. The problem with it is there's a space in your head between your skull and your brain. Unless you are somehow going to be able to invent something that you can drill a hole in their skull and put cushion around their brain, the injury comes from the brain hitting the skull, right? That's the force. It's the exterior force can be weakened with better helmets and headgear and all this other stuff that we've invented, but you're never going to be able to, unless you're able to put cushion around the brain inside the skull, stop these injuries from happening. It just can't happen. Okay. All right. Now let's talk about acquired brain injuries. We've talked about hypoxia. With my dad, you guys have already kind of heard about that. So the time has a huge impact on the injury. So without looking at your book, unless you've read it, about how many minutes do you have before, like if you have stopped breathing good air, either from drowning or from coughing, whatever it is, how many minutes do you have when brain cells start to die? Anyone got a guess?
I'm gonna
We
say
got 5, we got 3. Let's split it right down the middle. It's 4 minutes. 4 minutes without oxygen going to your brain is when brain cells start to die. Okay. Huge jump after 5 minutes. That's when permanent brain injury starts. Okay. 4 minutes. This is where they start to die. 5 minutes, permanent brain damage is happening. Okay. Quick responses. Huge. Like this is why with drowning, and they pull somebody out, like they start CPR immediately, try to get good breath, because if they're not getting that breath, you only have 4 to 5 minutes to try to get some oxygen in this person to their brain before brain cell starts to die. And when brain cells start to die, they get these acquired brain injuries. Yep. 4 minutes is when brain cells start to die. 5 minutes is when permanent brain damage. Okay. We've kind of talked about this a little bit already, but substance use, if they have overdose, this will cause them to lose consciousness. If you've ever seen a video or anything of somebody who has overdosed, they pretty much go white. And if you've never seen it before, there's lots of videos and things. If that's your thing, you want to look it up. But they go pretty much white. They're not breathing. They're not breathing. What happens? The brain cells are dying. So you have how many minutes? 4 minutes before brain cells start to die, 5 minutes until permanent brain damage starts. Okay. It doesn't mean they're going to die in 5 minutes. It means that the brain cells, once they're dead at that point, they're dead. They're not coming back. Well, that just depends on, I guess, how quick you run to the pearly gates. I mean, everybody's different. There's outside stories where people have lasted over 20 minutes and have come back fine, but statistically, it's 4 and 5 minutes. There are outliers. Yeah, I mean, man, you can find outliers to anything. Like you could look up people that's been dead for an hour and then their families called in to come say their final goodbyes and they like pop out of the, it just depends. Because as good as we are at medicine, it's hard to tell if maybe they have the most shallow breaths that aren't even traceable when they're getting a little bit of oxygen like that. That might extend the time some. Honestly, there's a lot of different factors that play into that. All right, so here's the different portions of the brain. So this is where Jordan was going with it. The different lobes. So if the injury is brought to the brain cells in the frontal lobe, this is where thought, memory, and behavior is going to be affected. Parietal lobe is language and touch. Occipital is in the back. That is your vision. The cerebellum, this is balance and coordination. The temporal lobe is hearing, learning, and emotions. And then the biggie is your brain stem. I want you to think of the brain stem as the most important part of your brain. Everything else, yes, it sucks if there's an injury to it and there's going to be lifelong complications. If there's an injury to brain stem, that's where a lot of people die. Okay. Because what it controls is your breathing, your heart rate, and your body's ability to control temperature. So the biggest things that your most important things your body does is controlled at the brain stem. Like I said, the other stuff also has massive effects, but like just keeping the person actually alive and their heart beating is the brain stem. Okay. Are there any questions? We're good so far? Cool. So let's look at the different types of impairments. So what are you going to be seeing from these different levels? And we're going to go through these Rancho's levels. The first one is a loss of consciousness, motor and muscle weakness, hemiparesis or hemiplegia, ataxia, vestibular difficulties, and so on and so forth. There's so many different kinds. But when will you see these impairments? What determines these impairments? How bad your injury was and what? Where it was. What lobe was it in? That's going to determine how bad the injury is or how bad the impairments are going to be. All right. You got me? All right, let's take a quick, and I mean quick break because we're gonna try to get through the biggest portion of this lecture today since we are recording it. Take like 3 minutes, come back, run to the bathroom, get a drink if you need to, stand up, stretch your legs, and then we're gonna start going through all the different ranchos levels. Okay? I've had a couple of people ask me what it is. I can help. Just remind me of advice.
Telephone.
I can help. It's way, people make that way harder than what it is. Guys, we're going to continue going through these. So, a ranchos level 1. So this is the lowest level of a ranchos. Is there a level 0? No, 1 is the lowest that somebody can score. Okay. So what does a Ranchos level 1 look like? They are unresponsive to external stimuli. So you're saying, hey, Ellie, wake up. Hey, hey, nothing, right? You walk up and you pinch her arm. Nothing. You go up and pick her arm up, try to give her a high five, and her arm just falls down. Nothing. Not responsive to external stimuli. Nothing. Okay. What are we focusing on in this? Because you're like, what? Okay, so if they're literally like a limp noodle laying in this bed, why do I care? This is one of the most important areas that you guys have to work on. And it sounds silly, but we're going back to the very basics of OTA, and that's positioning and passive range of motion. At the very bottom level of OT, that's what we're doing, the basic stuff. We have to do positioning because if their joints get contracted or anything like that, when they come out of this, that's going to be a huge barrier for them. You also have to make sure that they don't have skin breakdown because you don't want that to be on them either, right? So you're trying to avoid all these different areas. Basically, at this point is prevention therapy, correct? Got me? Yeah. Not always. So OT, a lot of times we are able to build what's called maintenance therapy. Like our goal was always to make somebody better, right? But it also can be preventing them from getting worse, right? So at this level, or somebody like that you're talking about, passive range of motion is extremely important because what have I taught you guys about if you don't use a section like, let's just say in your shoulder, what happens? You use it or lose it, but what happens? Contractures and it gets super tight. So now not only did somebody have an injury and they're going through this coma and they're going through this traumatic brain injury, but now you've thrown on top of them a frozen shoulder. And you're going to have to move a patient who doesn't know what's going on, who's extremely confused, and you're going to have to move their frozen shoulder. No, that's why that stuff is so important. Sometimes it feels like, what am I even doing? But you're making literally life-changing interventions by doing the very bare minimum that we talk about in OT. Yeah, pain contractures. That's my next point is orthotics. This is where a resting hand splint comes in to put their hand in a functional position. Because if you want something to get tight or if there's something like that's going to happen, you want it at least in a functional position, right? So that way it's easier to work with when they wake up. And then family education, talking to them about what it looks like, what's recovery look like, what are we going to go through these different levels, what does a Ranchos level 1 mean? Okay, there's another scale that's called the JFK Coma Recovery Scale. I'm not going to cover what it is. I want us to focus mainly on the Glasgow. Just know that it's another coma scale that can be used to help go through the stages of recovery. Okay, so that's basic on level 1. Level 2, let's jump up. So now they went from no response to what's called a generalized response. So inconsistently reacts to external stimuli. So now I'm like, hey, Ellie, and her eyes wake up and she's looking all around. She's not looking at me, but she's looking, right? She had some type of a response. Wasn't much, but there was something there. Okay. It's inconsistent. She might even look at me once, and then the next time I say it, she might look and totally look a different direction. It wasn't really at me. It's very inconsistent. So what does OT look like in this? Positioning, passive range of motion, hand orthotics, they're still very basic. At this point, maybe doing some environmental stuff, maybe doing some head control, maybe a little bit of head control and balance, trying to keep their head up. If you can get a more consistent response. I mean, at a level 2, you're still working at the very bottom of the barrel type stuff. But at this point too, maybe even getting a co-treatment in, trying to get a PT in there with you too, to try to get some more external stimulation, try to get joint compressions, all kinds of different stuff, whatever you feel like you want to do at that point. But at this second level, you're still working on the bare minimum basic stuff. Okay. Does that make sense? These levels don't, there's literally one change in every level as we go up. So they're fairly easy to remember. Generalized response. Level 1, there was no response. Level 2 is a generalized response. Okay. All right, so level 3, this is a localized response, but there's still total assist. So now I'm like, hey, Ellie, and she just looks at me. Okay, she has the response. She's not looking all over the room. She's looking at me whenever I tell her, right? That's the next step. Instead of being a generalized response and kind of sporadic, now it's localized. She's actually looking at me. Now that response might be a little delayed still, might be inconsistent, but overall now, when I yell her name, she looks at me. Okay? And I'll quit picking on Ellie and choose somebody else in a second. So what are we focusing on here? Now we're going to start throwing in some sensory stuff. We're going to be maybe doing a little hot and cold stuff, maybe doing a little bit of light touch versus deep pressure and all those different tests. You remember those from 209? Doing some of that stuff. Again, still positioning and orthotics, range of motion, maybe some active range of motion now, if they can follow those, if their response is appropriate enough. So you say, hey, raise your arm, hey, squeeze my hand, that type of thing. If it's consistent enough, you can work on some of that stuff. And now at this point, you need to find if they have increased tone. Okay. This is where that modified Ashworth scale comes in. Do you guys remember that from the tone lecture? This is where we're starting to play everything in together, especially these next 2 weeks. Okay. So the step up on this one is now they have a localized response. It's not generalized. Any questions on a level 3? Okay. Let's keep going up the ladder. We're up to a level 4. This one is a rather large jump. So now they're not having localized response, but they're having an agitated response and they're confused. So now I might come into the room and I say, hey, Sydney, would you like a sandwich? And she goes, bitch, get out of here. It's an agitated response. A lot of times they're going to curse at you. A lot of times it's going to be totally off the wall what they said. It's not going to match the question. You're like, what did that say? Or they might not even look at you and say anything because they're so confused. But at this point, I want you to remember agitated. Okay. They're no longer total assist either. They've now moved up to a max assist, which means you're doing how much work? 75. Very good. They're going to have bizarre behavior here. It's going to be inappropriate. Short-term memory is not going to be very good. Attention's not going to be very good. Impulsive. Their balance sucks. Safety awareness sucks. Their cognition is going to suck. And then they're not going to have a very good awareness of their deficits. So you're going to have a lot of safety stuff to work on here in this stage. So now instead of going from, I think what's kind of crazy about working with TBIs is the first 3 levels you work with the very basics of OT. Then you jump to level 4 and you need everything from every class you've ever been taught. Okay? You have to pull all your tricks out of the book in order to work with a level 4 and a 5. I'm going to tell you that we'll talk about that in a minute, but you're going to have to throw the book at this patient and try to find out what sticks, what they can do, what they can't do. But you got to understand that a lot of times as these patients are going through these Ranchos levels, their brain is healing. Okay. My dad probably started in a 3. He was in a 4 for a very short amount of time and then went, or a 4 and a 5, and he went up to 6 and onward in his recovery. But I can tell you at this stage, confused and agitated, you remember from my story about my dad, I told you about how he grabbed the steering wheel on the way to Morgantown, told the guy that he had a fence post stuck in his leg when he asked why he was there for a neurologist, like all these things. That's a level 4. Okay. When I fussed at him for trying to sleep in the Chick-fil-A booth, he got agitated. That's a level 4. Make sense? All right. So what are we working on? The OT focus on here is sensory stimulation is going to be a big part of it. Now you're going to start trying to work on attention and safety awareness. At this stage, safety is a huge part because they're such a danger to themselves. They're very impulsive thinkers. You know, this is a hard patient, hard level to work with. Behaviors are going to be big, like if their family wants to take them to church or something, not having them yell out in the middle of a sermon, or at a funeral, not having them laugh at the preacher or something like that. Like, you're really going to have to work on behaviors and appropriate behaviors and have them relearn that at this point. You can start doing some ADLs and IDLs, some basic stuff, maybe brushing teeth. I mean, I'm not going to hand them a knife and tell them to cut their steak. That's not happening at this point. Okay. And then balance and motor control, some functional mobility. You're starting to move into a little bit of a, still a lower end of OT, but basics, okay? This is the type of patient where I'm glad that we went over chapter 14 today. This is where you're going to see a lot of patients that are given what? Not wheelchair. Restraints. Yeah, because at this point they can be agitated to the point that they're combative and they're wanting to restrain the patient at that level. This is where I was trying to get at with that conversation earlier of, you know, why do people even want to use restraints with patients? It's because it's actually a danger to the patient. I worked with a client who was a TBI4, and that's where he was always going to be. He never made any progress. I think he was 20-ish years old, and he would spit and punch and kick, and we had the world's smallest PT at my facility. She was like 5 foot nothing, like maybe 110 pounds, maybe. She was just a tiny itty bitty person, very fierce but very small. And it was actually a danger for her to go in because he would hurt her. He was a rather large guy, very muscular. He was very big. I forget what happened, if it was like a birth thing or if it was an acquired later, but I mean, he would break her bones. Like, he was very, very strong and he very aggressive. So I would never, like, we always, if it was me or anybody, we always did co-treatments with that patient just because it was very, very dangerous. He was not allowed to be restrained. That's why we actually recommended that he be moved from our facility, because we weren't equipped to take care of that type of a behavior. We had a lot of older residents in my skilled nursing home. I don't know why it was ever admitted. That was admission's fault. And that facility, I wasn't. None, zero, doesn't matter. He sent a CNA to the hospital and we still couldn't use restraints. No, it sounds crazy. It does. But at the same time, you got to remember, he can't help that at all. And he has moments where he's very sweet and he would tell the therapist, "Oh, I love you so much and thank you so much." And then in literally the blink of an eye, he would lose his mind and start hitting and punching and spitting. So you can't strap him to a bed. I mean, if you did, that would be his whole life. It's him strapped to a bed the whole time. Yep. All right. Now let's move up to the next stage. So now we're going to go to level 5. The big step is they're no longer agitated. So they're confused. They might have inappropriate responses, but the agitation is gone at a level 5, and they're still max assist. Okay. My dad, he spent a couple days maybe in a level 5. He never was super combative or fighty. He would do some very dangerous type things like try to wreck us, but it was never him wanting to punch or hit anybody. At this level, they have decreased memory, decreased attention still. They have very poor insight into their deficits, but they also are going to require 24-hour supervision. Okay, because they're confused and what they do is not appropriate. So at this level, they can't be left alone. It's a shape. You insert a shape. So at this level, on a level 5, now that the agitation is gone, our focus, we're going to try to work on some cognition and orientation. So I would say at this point, like showing family pictures, trying to show them common objects and have them identifying it is good. An orientation board is really good. Working on their functional mobility, motor control, balance, and fine motor stuff, just some gross motor and fine motor stuff is going to be good at this level. Social awareness is also going to be good. If you have the ability to try to play out a scenario and say, how would you respond? Or put them in the scenario and how would you respond? Or there are standard videos where you can show them like inappropriate behaviors and say, okay, identify what is wrong in this scenario. How did they react wrong? Because you're literally retraining somebody almost how to have manners, which put yourself in that caregiver spot. That was very difficult with my dad to teach him how to have manners again, as him being my dad. And then ADLs, IDLs, and family education. So family education started when? Stage 1. It's always been there, right? And it's been in every stage since. Might be something to remember. All right, you guys stop me if you have a question about one of these levels, okay? The next stage is level 6. So now they're confused, but they have an appropriate response. So what did we lose? The inappropriate response. So now they're appropriately responding to situations. They're still confused, but we also moved up to a modified or a moderate assist level. Okay. I've got a video I'm going to show you in just a second. That's some students, not up here of another program made. So here they have decreased memory, but at this point you can start using things like external cues. So calendars, lists. This is that level I told you with my dad that I would write out a chore list for him every day that he had to have done, like unloading the dishwasher, taking a shower, but it was a checklist for him every day for him to go through. That's when you can start using it, is at a level 6. Okay. All right, confabulation. Does anybody know what that term means? If you can fab something, if you can fab a story or fabricate a story, what is that? It's a fake, right? What'd you say? Like you made it up, right? So one thing your brain absolutely hates is not knowing something. How many of you in here get frustrated when you're trying to remember something about a story and you just can't recall a certain detail? Your brain hates it. So what does your brain try to do? It tries to make it up, right? It tries to fill that gap. It hates that gap in that story. So it's literally going to convince you that what you said is right and it's totally an absolute lie and it's not the way it happened. This is the way or the reason that I can come and say, hey, Des, tell me about class last Tuesday. What did we go over? And you might, oh, yeah, this, right? And then I come and I say the same thing to Kelly, and Kelly's like, oh, it was this, and it's totally different than what you said. One of you is right, one of you is wrong, maybe both of you are wrong. That's because your brain made up that story. One way or another, you're going to have a fact in your head about that. This is why when you start telling about a story and then maybe your significant other or somebody else that was with you in the story, they slap you and say, no, that's not how that happened. And then you're like, no, that's totally how it happened. Somebody is right, somebody is wrong, or maybe you're both wrong. Right? This is another reason why eyewitness testimonies are bullcrap for any type of trial, because everybody's going to remember the story differently. And there's going to be, oh, he was wearing a red shirt when he stabbed the woman in the grocery store parking lot. And they're like, no, it was brown. Like, no, it was blue. He was 6 foot tall. No, he was 5 foot tall. He had hair. No, he was bald. Like, there's so many different stories they're not going to be able to collaborate with. Right? So it's really, eyewitness testimony is very questionable. Very questionable. This is why they put them up on the stands and they're like, hey, tell me about this. Oh, that doesn't match this story. And they try to pick apart your story. It's because there's inconsistencies. Okay, especially as time goes on, that story is going to change. So anyway, at a Ranchos level 6, confabulation comes in. This is where you'll start to talk to them about memories and things, and they're going to totally make something up because their brain is at the point where it is not happy that it has these gaps. So they're going to make it up. Okay. Next is they're going to have difficulty with initiating activity. Almost looks Parkinsonian-like. You guys remember we talked about Parkinson's disease? How they have difficulty initiating activity. It almost looks like that they're going to have, hey, I want you to start working on this crossword puzzle. And they just kind of stare at it, and then they might start. But the initiation is slow. They still need 24-hour supervision at this point, and they need a lot of structure. Lots of structure. So what does OT look like? Family education. You're still doing it. Still doing family education because that is very important. Balance and motor control stuff. Safety awareness is a big one. Adaptive equipment, but not to the point of like, here's all this brand new equipment. Let me show you how to use it. Maybe adaptive equipment that helps compensate for something like maybe medication alarms and stuff like that. Not necessarily like, here's a reacher and a shoehorn. Like, that's not what I want you to think of. Okay. Dual task practice. This means trying to do a couple things at one time. This is making the brain really work. And then cognition is another big point. So when you work with traumatic brain injury patients, don't get lost in the fact that you are trying to retrain the brain. And so if you want to put some of that in there, like following directions, being able to read directions for themselves, like let's say you did a cooking activity and you want them to make instant pudding. Make them measure everything themselves. Make them gather the stuff themselves. Make them do the whole thing as much as they possibly can by themselves. Okay? Very important because you want to retrain the brain how to do it for themselves. Okay? A lot of times as OT practitioners, we will set the patient up for the interventions too much. Okay? It depends on what the cooking task is. Like, don't stand up and have them make like a lasagna, but having them sit down and whip cold milk with pudding, sure, but make it appropriate, right? Like at this level, maybe whipping pudding is the best option. As we get further on, maybe a lasagna is a good idea. They have certain centers. Do you guys remember that one? I can't remember the name. It's in Georgia that the WVU's baseball head coach, his son went to, specializes in traumatic brain injuries. I forget what that place was called, but they have places that are just dedicated to working through these levels. So, but do you guys have something? No. Okay. All right, let's go to the next level. Level 7. Now it's an automatic appropriate response, and they're now at a min assist. So you're doing how much of the work? 25%. So now their appropriate behavior in a familiar setting like at church or at home or something that's more regular, a doctor's office, their behavior is now appropriate at this point. They still don't have great judgment and they still don't have great insight into their deficits, but they're playing along with what you want them to do, basically, at this point. Still needs supervision. And vocational rehab can start here. So learning their skills, higher level skills can kind of start here in a level 7. This is at that point with my dad that I knew he was going to go back to work as a toll collector. And so we bought Play Money and I would just practice like all the scenarios. All right, so a semi came through, has 4 axles. How much was it? Okay, you recall that, count out the money. He gave you $100 bill. How much change do you give him? And I worked on higher level rehab stuff. Okay. Stuff that I knew he was going to be having to do when he got to work. So our focus here are IDLs. So now we're moving from ADLs into more IDL stuff that are very specific to that person. So we're not really working on basics anymore. We're moving to the higher level IDL stuff. Okay. I didn't have a choice. Yeah, you really shouldn't, but I didn't have an option. Okay, adaptive techniques, teaching them a new way to do something might help. Strategies to manage ongoing cognitive deficits. Like my dad still, it's really good for him to use a calendar, but that's good for me too. Like I would forget half of the stuff in my life if I didn't put it on a calendar. But for his work schedule, he keeps a calendar. That's the only thing that's allowed to go on that calendar, that and haircuts. And he crosses off when he goes to work every day. It's just part of his routine now. He did not do that before. He was able to remember it just fine, but now that helps him keep up with it. Family education. Wow, it's continuing on, right? Still working with family education. Community outings are a big part here, like going out and, all right, let's buy a cup of coffee, do the social exchange, do the money exchange. All of that's part of it. And then at this point too, some group therapy might be appropriate because they can handle it now. All right, let's continue. Ranchos level 8. This is purposeful and appropriate response. So at this point, they are now doing things that are appropriate in their environment, and they're doing things that have purpose behind them. Their response is appropriate to their environment, not just familiar settings. So they're able to more generalize stuff and appropriate conversations. They still don't have great abstract thinking or problem solving skills at this point. At this point is where we're starting to think about, okay, what's our plan for going back to work? What's your transportation going to look like? At this point, you can consider a driving evaluation or driving rehab. I told you guys this is one of the most scary things ever that I did with my dad. When he got to this level and I did driving with him, I was plumb terrified. But the difference it made in him was massive. I told you guys he came home and was just bawling, just crying because it meant so much to him that he was able to drive. He never thought he was going to be able to do it again. So it's important, but it's very scary. They're still going to need 24-hour supervision at this point, and they still need structure. But you're starting to get more toward, at a Ranchos level 8, I started leaving my dad alone for short periods of time just to see how he would react. What would he do? And at a Ranchos level 8, because he needed so much structure, unless it was given to him on a list, he wasn't going to do it. So it was really difficult to get him to think out. It still is difficult for him to think outside of the box on things that need done. But he doesn't quite need a list anymore. But the 24-hour supervision here, I get why they put it, because they still have some difficulty with the abstract thinking and problem solving. It's a safety issue. So if the house is on fire, what do I do? That skill, still not there. Okay. So that's why they say 24-hour supervision. It's not necessarily they're a danger to themselves or that they're going to do something dangerous. It's more if something happens, can they react to it? That's why they say 24-hour supervision. Okay. All right. So our focus is family education. It continues. Higher level cognitive tasks at this point. I had my dad doing some higher level math stuff, some bill management, things like that. I did have him do a lot of problem solving skills. Like if your water heater were to bust, what do you do? What's your first thing? I need to go cut off the water. Like that's what I'm looking for. What's the direct, immediate response? Started working on that. Adaptive strategies, how to do things differently, and then explore leisure at this point. So now you're moved past just ADLs and IDLs. Now you're moving into some leisure stuff. What do they like to do? Go bowling or play ping pong or anything like that. Okay. Any questions on those 8 so far? Got 2 more to work. Well, 3, but the third one's just kind of there. Good. Good. All right, so level 9, now it's a purposeful and appropriate response, the same as a level 8, but now they need standby assistance only if they need it. So basically what that means is that they need help only when they ask for it. Like, hey, can you help me with this? Okay. They can transition between tasks about every 2 hours at this point. So really give them a lot of time to finish a task before, it's all good and done. You can start looking at work and going back to work at a level 9. It might not look exactly the same, but you can start looking at different types of availability, doing voc rehab. Our focus here is to increase overall occupational performance and teach comp strategies. That's pretty much it. It's not, but it continues. Family education is never going to go away. But now really at level 9, the reason that it's not on the slide is because you're now transitioning a lot of your education to the person because they can tolerate it, right? Like at this level, you're talking about specific job duties for them to go back to work and starting to look at that kind of stuff. They have to pass the driving eval. Oh yeah, it's definitely person specific. Like, for example, if somebody had TBI and they were a house rep in Charleston, like the voc rehab in order to go back to that is going to be vastly different than if they're a Walmart greeter, right? It just depends on what their job responsibilities are. As far as driving, it just depends on where was the TBIs, their visual changes. There's lots of factors that go into that. It's just going to depend on the person. Some people will never get there. Some people will get there faster than others. Okay. All right, so our last official level here is a Ranchos level 10. Now they're at purposeful and appropriate, but the biggest one here, the biggest change is their assist level. Now they're modified independent. Okay, so they're independent, and with whatever tools that they need to have, they've got them, and they're independent in what they need to do. They might still require some extra time to do things or a comp strategy to do it. But now you can start working on multitasking too, like jumping back and forth between things. That 2-hour gap is not there anymore. Our focus here is definitely work, the highest level of things that we do, like the work retraining, specific skills. But that's like our majority is work retrainings. Okay. Yep. Yep. And they are listed on page 988. Okay. I'm sorry. So let's talk about social interactions with TBIs. So they need to be, before you put them in a social interaction, they have to at least be a level 7, right? So if they're at a level 7, then you can throw in social interactions and start working on it. Anything before that, you're just kind of doing nothing or doing something for no reason. It might embarrass them and it's just not appropriate. So if I have a situation where I give you on a practical that you have a Ranchos level 5 and you come in and start talking about social interaction skills, you're not going to pass because it's not appropriate. Okay, that's why these levels are so important, is so you can choose interventions that are appropriate for the level they're at. Okay. All wherever, just depends. My dad was hospital to home, and then he had a little outpatient, and that was pretty much it. Nope. This could be a long time before somebody reaches their max level. It just depends on the person, how bad the injury was. Some people don't ever get that level. So some interventions again for social interaction, role playing, modeling behavior, and then community outings and community reintegration. But that has to start after level 7. Okay. Set level 7 and after, sorry, at least level 7. Okay. So client and family education, I mentioned it in every slide. This is our last slide of information. So keep your attention with me for a couple more minutes. I mentioned it so many times because you have to include the family in this. Why? We didn't even get away from really family education to like a level 9. So why? Well, right, the caregiver, but think about the recovery of a brain. Why are we so focused on family education and not the patient? Right. They can't do it. They literally cannot do it. You might teach them a new way for them to do something. They're going to forget it immediately when you walk out the door. Their brain literally cannot do what you're asking them to do, but you still want to practice these skills. So that's why it's so important to get the family, because you're going to have maybe 30 minutes or an hour with them. If you get the family doing these things at home or in facility that are spending hours with them, whatever it might be, if you're getting them involved in the treatment, you're going to have a better outcome. So I want to bring you back to our stroke lecture. What's the huge rule with strokes in recovery? There's two things. What is it? Time and repetition, because strokes are brain injuries. Okay. So the recovery looks oddly similar to each other because strokes are a brain injury. So there's a lot of tie over between these two chapters. They need lots of time and they need lots of repetitions. Okay. All right. So back to the family part of it. Some things that you're going to be working on. The biggest one is safety. There was with my dad, there was some safety things. It was more of him looking down to make sure he wasn't going to trip over stuff. That was one of his biggest ones, but that's something you can talk to about for safety. Cognitive issues, what to expect, how to address it, balance, ADLs, everything, because the family is going to be the primary caregiver. A lot of instances, like I told you with my dad, he did not go to a facility. He went from hospital, 2 days in the hospital, to home at a ranchos level, probably 4-ish, 5-ish. Okay. More along the lines of a 5. But nonetheless, we were thrown into that situation, and luckily we were educated and trained how to do that stuff. Most families aren't. So it's very important that you discuss every aspect of the stuff with the family. Okay? Because if you try to do it with the patient, they literally cannot do it. Okay? All right. Here is your knowledge assessment for today. Pretty straightforward. Match the level of ranchos with these behaviors. And I'm going to leave this due on Thursday. Okay. Because you guys have 3 case studies that are due tonight for chapter 14. So I'm leaving this to Thursday because we're going to continue in traumatic brain injuries on Thursday. And yes, you can whine and moan, but we're doing a practice practical in here on TBIs on Thursday. Okay. But we're also going to do something fun too. So I'm going to try to spend almost the entire day on Thursday doing some hands-on stuff. We're going to do a little bit of lecture still for Jerry's on Thursday, but nonetheless, I want to spend a lot of time doing some hands-on practice stuff. Okay. Hang on a second. I'm going to stop my recording.